morning, everyone. This morning it's my privilege to introduce Dr. Wessels. He's the expert in thrombosis and haemostasis. He studied at the University of Pretoria and also completed his MMed at University of Pretoria. He then specialized at Wits, and then he actually worked as a pathologist at Niehaus and Botha from 1994 to 2004. And since then, he's worked at Ampath, and he's a very well-known consultant in haematology, the expert with all thrombosis and bleeding disorders. So today we're looking forward for Pete's presentation. He's going to talk about thrombosis in rheumatology patients. So thank you, Pete, and we're looking forward to the presentation.
Thank you. I just want to confirm you can hear me well.
Yes, we can.
Good.
I'm just going to mute us.
Yes, indeed. Okay. So I'm not going, I'm sure you all thought, this is going to be antiphospholipid syndrome. It will be a little bit antiphospholipid at all. It's actually most about other things. So we're going to look at thrombosis in rheumatic disease and three headings. The one, immunothrombosis, just an explanation, because I think we all know about it, but we don't really think about it that much. I don't think we need to think that much, but as long as we know about it. And then arterial disease, and then venous thromboembolism. I think arterial disease in the rheumatoid arthritis patient, for example, is really underestimated, but we'll have a look at it. Just for my own education and for everybody else, I'm sure you know this much better than what I do, but the inflammatory pathway consists of the three or the four groups. The first is the inducer of the pathway, and those are the DAMPs and the PAMPs. PAMPs are pathogen-associated molecular patterns. For example, the pattern on a virus that activates the whole process. The DAMPs are all the damage-associated molecular patterns, and they've got names and stuff. Nobody knows it. The HMGB1, high mobility group box 1, for example. It's all nonsense words. But we know about DNA, we know about ADP, we know about ATP. And those, when a cell gets damaged, all those proteins should be removed. And those proteins are really messengers to our innate immune system. You remember we've got the adapted and the innate immune system, that acts immediately. And on certain cells, there are toll-like receptors, that TLR, that's not a T-cell receptor, that's a toll-like, which identifies these damage-associated molecular patterns and the pathogen-associated patterns. And these are the macrophages, the dendritic cells, which are all family of each other, mast cells, all family of each other, and some platelets also, some of these sensors. And once they sense this damage in an area, they then release mediators called interleukin 6, especially interleukin 1, and tumor necrosis factor, and then other CCL2, nobody needs to know this, histamine, bradykinin, and that's the response from these cells. So, and then we have the effector organ, but just to keep in mind, that's what really happens. If we look at platelets, now platelets are absolute fantastic little, well, we call them cells, but they're not cells. They actually haven't got a real nucleus. A platelet is just a break-off product of a mother or father cell in the bone marrow. We make about 2.5 billion per kilogram per day. We replace our platelets every 7 days. And platelets are wonderful in the sense that they're discoid shapes. They've got inside of them, they've got some lysozymes, they've got granules, dense granules, and alpha granules. And you can see the stuff inside that alpha granule. For example, that alpha granule's got von Willebrand factor, fibrinogen, platelet factor 4, P-selectin, all those, platelet-derived growth factor, that's a PDGF. We had an old professor many, 40 years ago that used to talk about letterketal, letter language. And I wonder what he would have said, because CLL to him was a letter language, but today he would cry. Anyway, so we've got those alpha granules, and if you look at those, the alpha granule content, you can see von Willebrand factor, that's the sticky protein in our blood. Very important to form clots. Fibrinogen, especially in that initial primary hemostatic time. Fibrinogen, which is forms the scaffold after the clotting cascade is run. Platelet factor 4, which is an interesting little structure. And the platelet factor 4 really attaches to the sides where an injury has happened on the endothelial cell surface. It attaches to glycosaminoglycans, which are little, that's got an anticoagulant effect. So that it actually causes, it stops the process, actually enhances the process of clotting in that area. It blocks the anticoagulant effect. That's the platelet factor 4. And there are a whole lot of new disorders that we call the antiplatelet factor 4 disorders. And they're really interesting. The one that everybody knows about is TTP. Not TTP, heparin-induced thrombocytopenia. And there are a lot of them these days. For example, after vaccines, we also developed antibodies against platelet factor 4. Anyway, so those are the alpha granules. I should continue. Then the dense granules, ADP, ATP. Now you can see those two are DAMPs, serotonin, polyphosphate, calcium. Calcium really is factor 4 in the clotting cascade. And you can see, in other words, what the platelet does. It's really enhancing clot formation. And platelets circulate in the blood happily. They get activated by shear stress if they rub against the vessel wall. But platelets are not activated. Certain conditions activate platelets. On their surface, they've got glycoprotein receptors, and these receptors attach, for example, to subendothelial structures like collagen, and it can attach to fibrin and fibrinogen. So what the platelet function, we always thought that platelet function is really to enhance coagulation and immediately seal off with a clotting cascade a leak in the system. But it's not true. Platelets are really, and you can see this if you want to read something interesting, platelets as the central hubs of inflammation. Platelets play a critical role in the inflammation process. And let me show you here. And remember I said we've got the DAMPs and the PAMPs, and we've got platelet activation. And platelets also gets activated as soon as your endothelial, it can sense the endothelial cell damage. If there's endothelial cell damage. Now, we underestimate the endothelial cell, so something about the endothelial cell as well. We should continue with the talk, but let me just quickly show you this. So if there's endothelial damage, the platelet senses it, it gets activated, it attaches to the endothelial cell and releases this content. And this content, amongst other things, P-selectin, remember P-selectin sits there, and P-selectin then can activate neutrophils. At the same time of endothelial damage, the endothelial cell will put on the surface some markers, ECAMs and VCAMs, that calls the neutrophils to the area. And neutrophils then break up and they throw out their nucleus. Now, that's an interesting thing. It's called mitosis. And we've learned lately that, but in the last few years, if you're older, it's lately, we've learned that neutrophils can throw out their nucleus. And that's a way to catch bacteria and viruses for the macrophages, or to kill them with the enzymes. Neutrophils have got peroxidase inside, myeloperoxidase, and they can release this. And this whole process then forms clots, and that's immune thrombosis. And that's really what happened with, which still happens, but that's what happened with COVID. Remember, with the endothelial cell, so that's the role of a platelet. So platelets, bottom line, we always thought platelets are really procoagulants and they seal off, but it's the system. It's not true. Platelets are really pivotal players in the immune system. That's an endothelial cell, and here you can see an activated platelet, and it's got that little box thingy release, and it's got TGF beta release, all these interleukins and DAMPs, and those can activate your endothelial cell, and the endothelial cell then changes its whole structure, and there you can see it puts out the ECAMs, the VCAMs, and the endothelial cell then further sends out messengers, IL-6 and IL-8. So we can go into depth, but it's ridiculous. Bottom line is this. The endothelial cell, again, we always thought, if a few years ago, we would think the endothelial cell is really the smooth inner liner of the vascular system. It is true, it's very important. It's interesting, in endothelial cell, they like cobblestones on the inside of the arteries, veins, and capillaries. And in different organs, they totally act differently. It's the same cell, and it's according to various factors. For example, if an endothelial cell, if you want to grow endothelial cells and you put them in a plate and you grow them, they won't really grow. They need a pulse of blood flow to enhance their growth. And if the injuries, they can start growing into another area. So they can, that's the angiogenesis. So you can form new capillaries in the area that you've got injury. But that's one of the functions of the endothelial cell. But the endothelial cell, we always thought it's a barrier. And the way that it forms this barrier, on the outside of the endothelial cell, there's a scaffold or a structure. And this scaffold keeps the cells away from the endothelial cell. That's one of the, it's got a negative surface. And it keeps the cells away, so the platelet stays inside and don't unnecessarily come and sit here. And the red cell stays inside, and the white cells stay inside. So, and on top of that endothelial cells, we've got the structure. And inside that structure, amongst other things, something called glycosaminoglycans, GAGs. Now, GAGs, it's really heparin. So we form our own heparin on top of the endothelial cell. And that's one of the ways that it's a smooth inner liner. So it forms the inner liner, but it's really an endocrine organ. I showed you that it releases some interleukins. It's also the barrier function. This is what this picture shows. An endothelial cell has got a fantastic way of controlling the size of the artery, vein, especially capillaries, the size of, because it can change the size. It senses, it's got fantastic sensors. For example, on the surface of that glycocalyx that I said, that's on top of the endothelial cell, goes into the cell. And pushing that glycocalyx, according to your blood pressure, will change the message inside the cell. So if that pressure increases, the cell will sense it and send out messages. And it will, for example, then make more nitrous oxide, and the cell will then cause the hole. It will it will change in shape, and the capillary will dilate. It also has an effect. The endothelial cell can even affect the platelets in the area. So endothelial cells are mostly in a relaxed state. We all want our endothelial, and I think that's why our Apple Watch just tells us breathe in, or you should take a break. All those type of things, we need to relax, and our endothelial cells need, because they sense what's happening. For example, in diabetic, it's the endothelial cell is not happy. The endothelial cell, if you smoke, the endothelial cell is not, you get endothelial damage. Now, that endothelial cell, as I said, I'm going to spend 2 more minutes on physiology, because otherwise we won't get to the rest. That endothelial cell, the inner lining of the, it controls the flow out of the vascular system, from the blood to the tissues. So it's movement of fluids, macromolecules, hormones, etc. And as I said, it also on the surface, if it senses that there's trouble in this area, it will, and you need help, it will put on the surface some ECAMs and VCAMs, and the white cells will be then directed. And the neutrophils circulating here, they kamikaze pilots, they never go back. Once they get stuck onto this endothelial cell, it will move through into the tissue, break up, release the, do a little bit of mitosis, kills whatever it is with the enzymes, and catch the thieves and the bacteria and viruses that are there. So that endothelial cell really is, it's got white cell direction. And then the last wonderful thing, and that's what we really are talking about today, is the hemostatic function of the endothelial cell. Now, most of the time, the endothelial cell, as I said, they form a smooth inner liner inside the vascular system with glycosaminoglycans. They release various things. They release, for example, tissue factor pathway inhibitor, which is the anticoagulant that stops the initial phase of coagulation. They release TPA. TPA is is our own thrombolysis. So they release TPA to prevent buildup of fibrin strands. And it's interesting, you remember we always say that a patient must be mobilized as soon as post-surgery. And that's because our calf veins and arteries will release TPA once we start walking. And that TPA will then prevent clot formation. So in most of the time, if we're relaxed and we are in a normal state, and there's no trouble, and we haven't got underlying inflammation, etc., that endothelial cell is really in a state of relaxation, and it's got an anticoagulant effect. But inside that endothelial cell, and the normal process, the reason why we have these endothelial cells and platelets, if there's a break in the system, if you have a break in the vascular system, you expose immediately the subendothelial structures, and those are collagen, and there's an envelope of von Willebrand around there, and that exposes the collagen and the von Willebrand factor. Platelets will have GP receptors for those, they will get stuck on there. And endothelial cell injury in that area will also release inside the endothelial cell. On the surface, there's little things called Vival Palladi bodies, and those are full of von Willebrand factor, and they will release that von Willebrand factor, which is really, they release it in a big chunk of glue, and the cells will get stuck, and the glue and the coagulation cascade will start running, and the platelets will release. Will give phospholipids to this process. It will break up in small parts, and they will form a clot, and you seal off that area with a glue, with a von Willebrand that you've left, etc. But in certain circumstances, if there's activation of these endothelial cells, they do that same thing. And now it's a different kettle of fish, because now they release these large blobs of glue, this von Willebrand factor, and normally, on their surface, they've got a little scissor called Adam TS13, and that scissor cuts into smaller pieces. And if the endothelial cell is sick or injured, it cannot cut that into smaller pieces. So you release these big von Willebrand glue pieces if you have endothelial injury. And that's really, again, what happened with COVID. We have this hypercoagulability in the capillary system. There are many other things that they do. On their surface, once they get sick, they express tissue factor. Tissue factor is the first step. Tissue factor is the first step. We have a little bit of factor 10 that's active. Tissue factor will attach to that, and the coagulation cascade will run. So the bottom line is this: we've got endothelial cells and platelets, and the original function is really to prevent us from bleeding. But if we have an inflammatory process or chronic injury to our endothelial cells, they get sick and they can't, and then they become procoagulants and not anticoagulants. They function, it's more prone to clot formation. I'm not going to say more about the physiology. That's just the whole thing. And what really, why did I say such a lot of nonsense? The immunothrombosis is really a vicious cycle between the platelets. Remember I said platelets now get activated, the endothelial cell, and they release interleukins, and the innate immune cells pick up all these damps, and this whole process starts running, and you get your coagulation cascade running. There's that tissue factor expression on the endothelial cell, the coagulation cascade starts running. You get your neutrophils with your ICAMs and VCAMs, they sense this. They release, platelets get caught into that, and you form a clot. So this is really the problem. The problem with many disorders, and this is the problem with diabetes, this is the problem with hypertension, etc., that you get sick endothelial cells. You need to keep your endothelial cells happy. And it's got a lot of, unfortunately, to do with genetics as well. But this is a mismatch, and this is what immunothrombosis is. It's this constant activation without into it. And this is just a summary of what I said. I'm not going to go through it. You're going to kill me if I say anything more. Now, what about arterial disease? If you look at patients with rheumatoid arthritis, or let's say you look at patients, we know arterial disease, we know the causes. We've got lifestyle. If you look at this is from an article not too long ago, 2023. We've got the lifestyle factors, we've got stress, we've got the microbiome, which is more and more important in atherosclerosis. We've got certain clonal hematopoiesis, CHIPs, etc., where we have abnormal bone marrow, genetic factors, we know that. Traditional factors, hypertension, diabetes, low estrogen, high LDA, lipo small a, all these factors play a role, and then we know these, and then we have atherosclerosis forming. The process of atherosclerosis, we know what really happens. You get endothelial damage. the lipoprotein, small lipoproteins can move underneath the endothelial cell. The macrophages decide we must eat all that crap underneath, so they get there, they eat it, they form foam cells, they become bigger and bigger, and they burst, and you get calcification in that area, and the whole artery gets clogged up, and then the big thing then is the risk of rupture, because as soon as that rupture, you expose the digested lipids to the blood, and you get a clot formation in that area. So if we look at all the normal reasons why somebody would get atherosclerosis, and you then compare that to a patient with rheumatoid arthritis with the same normal reasons, if you take, there's 103% higher cardiovascular risk if you've got rheumatoid arthritis, and if you're female, and in male 65%. And I think we underestimate this risk of arterial disease in all our autoimmune disorders. So what am I really saying is, you've got the baseline risk in any patient, then, and those are the age, genetics, hypertension, hyperlipidemia, lipo small a, etc., LDL, those play a role, and that's, you need those to get stuck under the endothelial cell. But then we have this autoimmune disorder, and as I told you, you've got this sick endothelial cell, you've got your B and T cell, which stops this process, also defective. So there's a process of enhanced atherosclerosis. And then we add certain, if you use more than 7.5 milligrams of corticosteroids per day on a long term, you might also increase the risk, you do increase the risk of atherosclerosis. And some of the NSAIDs also can play a role. And here you can see some of the antiplatelet or anti-inflammatory drugs, what they can do to the system. To give you an idea, brufen, it stops your endothelial cells from going. So if you had a cardiac bypass and you take brufen, you're really in trouble, because it stops the smooth cells, the arteries, capillaries there, endothelial growth. And I'm not going to, we all know about this, I'm not going to spend time. If we then look at the disorders, remember we said it's double. We underestimate the arterial risk in rheumatoid arthritis, double the risk in females. There's rheumatoid arthritis, and we know that there are more females with rheumatoid arthritis. And the primary cardiac, they have an increased atherosclerotic plaque, but that plaque rupture is much higher in rheumatoid arthritis. So they've got a 45% increased risk of cardiovascular death. So rheumatoid arthritis in a female, look at their cholesterol, treat them. If they need a statin, give them the statin. SLE, same thing. We're going to say something about SLE, but there's a 50-fold increased risk in women premenopausal if they've got it for myocardial infarcts. Sclerosis, the primary target is myocardium, antiphospholipid syndrome, coagulation system, we'll say something about it, that crushes the major arteries, major branches of the aorta, we know that. And there your risk is aneurysm formation. But you can see here, it's really in all the different conditions. I've taken rheumatoid arthritis as an example. So if we just sum it up, we've got the hazards, and we've got the protectors. And it's interesting, if you start treating these patients for their autoimmune disorder, you decrease the plaque formation as well with all these drugs. And that's why people starting to give colchicine to patients with atherosclerosis. So, and here, remember we said platelets. We always thought platelets are just procoagulants. We now know that they're really directors and conductors in the immune system. And you can see what has been suggested and has been found. This is also from an article, that same article, where we may get to a future where platelets play a more, or antiplatelet therapy might play a bigger role in treatment of immune disorders. So that's arterial. I gave you some ideas on immunothrombosis, and I said something about arterial disease, and the rest of 20 minutes, we're going to talk about venous thrombosis. And I don't need to say this, but Rudolf Virchow, more than 150 years ago, much more, 170 years ago, said that if we will form a clot if we've got hypercoagulability, endothelial damage, and stasis of blood. And here you can see inflammation definitely causes hypercoagulability. And I just explained to you how bad endothelial damage is. And then blood flow important. But inflammation, definitely, two of the causes. And many times these patients with inflammation are also immobile. So you've got the full circle, all three factors forming clot formation, venous clot formation. Now, already in 2012, you can see here the major diseases presenting with inflammation-induced thrombosis. And here you can see the well-known culprits again, and you can see which vessels are involved and what is the possible mechanism. And what we really know about autoimmune disorders or rheumatic disorders and venous thrombosis, that it depends on the type of disorder. They're not all the same. There's a big difference. Rheumatoid arthritis has got the arterial disease. They do have venous disease as well, but much less. Antiphospholipid syndrome, arterial and venous. So the type of the disorder will define the risk. Also the stage of the disorder. If you've got a disease with flares, that is the time that the patient is at risk. Not all the time, only at the time of flare. And it also depends on the treatment that you give a patient. I told you if you give a patient high doses of steroids, it makes them, it increases their risk for venous thrombosis as well. Now, if we look at a more recent review, and this is a good review. If you're interested in this is a good review to read. It's in 2023. So if we then look, it's the same type of story. It's you look at the different diseases, you see what is the risk. We're now talking about venous disease. Remember, there's a difference in the pathogenesis between arterial and venous thrombosis. But if we look at the incidence of venous disease in these patients, let's take a look at SLE. This is now SLE, and remember about 40% of patients with SLE will have antiphospholipid, 10 to 40%, max 40, depends on what you look at. But 10 to 40% of patients with SLE will have antiphospholipid antibodies. So there's more than just the antiphospholipid antibodies. It's this inflammatory process, the immunothrombosis that I explained to you. So there's an 8% cumulative incidence of venous thromboembolism in SLE. And you can see it's a generalized hypercoagulability and antiphospholipid with some. Irritable bowel syndrome or IBD, it depends on what you're talking about. If you talk about Crohn's disease, there's the hazard ratio is 2.2. And ulcerative colitis, if a patient presents with an unprovoked DVT, I think an important question to that patient is, do you have gastrointestinal symptoms? In other words, do you have diarrhea, do you have blood in your stools, etc. Not only for colon carcinoma, but also to make the diagnosis, because it often gives an unprovoked VTE in these patients. And this is enteric microthrombosis, high interleukin 6, increased thrombopoietin, and it's mostly at the time of the flare of the disease and at the time of hospitalization that Crohn's and ulcerative colitis got that problem. The myositis is dermatomyositis got a little bit of a higher risk compared to polymyositis, and this is because of the inflammation, and it's mostly in the first year. It increases with age. Everything increases with age. Risk for everything increases with age, but in the first year of diagnosis is the time. So you're not going to give a patient with you're not going to give all patients with polymyositis or dermatomyositis permanently anticoagulation. You may consider it depending on underlying other factors. At the time of hospitalization, you should give it, or if they've got a flare at the time. What about your vasculitis? Large vessels, you can see the giant cell arteritis. What is the risk? PAN, you can see the risk. And then the important ones, the ANCA-positive patients, and that's why we often do the ANCA with vasculitis, because they've got the incidence is much higher of VTE. Okay, and we know that Bichet can present with superficial thrombosis. Systemic sclerosis, you can see here the cumulative incidence of rheumatoid arthritis, much less for venous disease, sarcoidosis, Sjogren's, and you can see here depends on the activity of the disease and other risk factors. For example, if a patient is admitted or not. The message is really not all patients with the autoimmune disease needs to be put on an anticoagulant. Just to show you again, the vasculitis, you can read it if you don't know it, if you don't need to know it if you don't work with it. And just to explain again why I say I'm not saying that everybody with a rheumatoid or underlying autoimmune disorder needs to be permanently on anticoagulation, but there are danger zones in the first year, for example. Remember I told you, autoimmune disease, autoimmune hemolytic disease, in the first 90 days, they have an increased risk. Sjogren's, 7 times increased risk in the first year, and your myositis is, both of them increased risk in that first year. So that's the time that you should be worried. If you admit them, definitely then cover them. Your inflammatory bowel disorders, sharp spike during the time that you admit them, and then there's this progressive accumulation over time in rheumatoid arthritis and splenic sclerosis. So that's the story about the different underlying conditions and the risk of venous thrombosis. If we now have a patient, if we look at the risk of recurrence, the patient's got SLE, and we look at the risk of recurrence. To consider risk of recurrence, we always look at what happened at the time of the deep vein thrombosis. For example, if a patient, if it was provoked, in other words, the patient had flu, he was in bed, and he also had a plaster of Paris on his leg. I mean, if he then gets a deep vein thrombosis, it's a provoked thrombosis. But a patient that did nothing, normal run-of-the-mill, not immobilized, not sick, that's an unprovoked. So if we looked at a provoked deep vein thrombosis, we know the risk is lower to develop a thrombosis. But if they have SLE as well, look at their risk is much higher. The highest risk is if it's an unprovoked, a patient with an unprovoked deep vein thrombosis and SLE, look at their risk of recurrence. You can see the risk of recurrence is dramatic. Just to give you, this is patients with SLE and antiphospholipid antibodies. Look at that, 16.7 times increased risk. So we're going to quickly to say something about antiphospholipid syndrome, just because I've got a lot of respect for this disorder. It's a different scale. If you look at that cumulative incidence that I showed you there, none of them close to this. 39% historical VTE rate, 14 to 17% recurrent rate within a year. So if you have a patient with antiphospholipid syndrome, they should be permanently, once they get it, well, you won't make the diagnosis of antiphospholipid syndrome if they haven't got a clinical picture. In other words, either obstetric, venous, or arterial disease. Once they've had that, they should be permanently on anticoagulation. And if we put this into the graph now, suddenly we see a total different picture. You can see it's on top of all this. And I've explained to you previously, we had a talk about antiphospholipid. Protein S, protein C decreased. Endothelitis, activating immune system. Various problems, hypercoagulability, platelets in a different state, endothelial cells in a different state. And the multipliers in this condition is really this whether it's one antibody, more than one antibody, or all three test positive. So a triple positive antiphospholipid syndrome is something to really be worried about. I'm not going to talk about this again, but people often think that antiphospholipid syndrome is a genetic disorder. There is a tendency, a predisposition. And you can see if a patient's got that DR4 or DRW53 HLA, they tend to cluster in those patients, but you can't, it's not, and I think the idea of antiphospholipid syndrome being a congenital disorder is because of the testing, where you do a hypercoagulable screen and it's lumped with protein S, protein C deficiency, antithrombin deficiency, etc. But just to again show you that the most common presenting clinical manifestation of antiphospholipid syndrome is really deep vein thrombosis. And there we see these antibodies. We can have a lupus anticoagulant, which is really a clot-based assay, anticardiolipin antibodies, and anti-beta-2 glycoprotein antibodies. These antibodies are directed against the phospholipids, but then various other ones, and that's why people say maybe we should look at this and reclass and not use the standard classification. But this is the revised Sephora way of doing or confirming antiphospholipid syndrome. You need to have a clinical manifestation, arterial, venous, or thrombosis, microvascular thrombosis, or obstetric complications, and we all know that, plus the laboratory testing. So you need either the lupus anticoagulant positive or the anticardiolipin or the beta-2 glycoprotein positive. And this test must be repeated within 3 months, and it must be done in a 5-year period. And then only can you make this diagnosis, because this is a serious label to hang around the head of a patient. And we all know that there are many other manifestations of antiphospholipid syndrome. Shouldn't that be taken into consideration? And that's where the EULAR classification comes in, where they say maybe we should use those, and not only venous, arterial, microvascular, and obstetric complications, but we're not yet there. And there's also a feeling that maybe the other antibodies against antiphospholipids may play a role. You can see some of these antibodies, but we're not there yet. And I'm not going to spend time here, but you can see that's the way that we do it at present. This is the suggested way, where we have different types of antiphospholipid, microvascular type, macrovascular type, obstetric type, cardiovalve type, rheumatological type. But I think that's probably for future use and probably only for research at the moment. So what happens? Why do we have thrombosis in antiphospholipid syndrome? We've got endothelial activation and injury. We've got neutrophil traps. We've got platelet aggregation, and we've got the cascade running, the coagulation cascade. So the full story. Just again to remind you, if you look at healthy donors, they've got antiphospholipid antibodies. 9.4% have IgM, and 6.5% will have IgG. So it doesn't mean if you've got antibodies that you've got the disorder. You need a second hit. You get the first hit where you form these antibodies. The second hit, only after the second hit where you get your phenotypic expression of this disorder will you make the diagnosis. And here you can see what causes the first hit. You can have, I told you about the HLA types. Some infections can cause it, older age, as I said, the risk for everything increased. malignancies can cause it, and then you get your second hit, infections, cancer, procoagulant drugs, etc. So if we then look at, if somebody is a carrier, you have a patient, they have antiphospholipid antibodies, but they've never had any obstetric problem, they've never had any thrombosis. If you give them a contraceptive, look at the risk, stroke risk, myocardial infarct risk, very high. Previous thrombosis, if they had a previous thrombosis, what is the risk of recurrence? 24% arterial recurrence, 15.4% venous recurrence. If they also have SLE, they have an increased risk because as I said, you might have antiphospholipid syndrome without SLE. Rheumatoid arthritis may have antiphospholipid antibodies. So, and I think the one thing I want to show you is thrombocytopenia. If a patient that has antibodies develop a thrombocytopenia, you should be really worried because it's a sign of activity of the disease. And I quickly want to show you this. If you have antiphospholipid syndrome and a patient develops thrombocytopenia, 20% of them, or 1/5 of patients will develop a thrombocytopenia. But in those that develop a thrombocytopenia, if you look at patients with a thrombotic incidence, 20% will have a thrombocytopenia as well. So, and it doesn't, there's no dependency on the degree of thrombocytopenia. There's a correlation with systemic manifestations, but in my mind, the biggest concern is thrombocytopenia is often a predictor of catastrophic antiphospholipid syndrome, which we're all really scared about. So don't underestimate the platelet count changes in a patient with antiphospholipid antibodies. What do we do with them? We give them low, and these are the patients they're carriers. They haven't got the disorder yet. What do? We give them aspirin. We might give them hydroxychloroquine as well, because that decreases platelet function as well. We may give them thromboprophylaxis in at-risk conditions. What do we do if they've had a venous thromboembolism? We tend to give them warfarin. The DOACs are not the ideal drug. If a patient is on a DOAC doing well and it's not triple positive, you can consider with the patient's consent to continue with the DOAC. What about arterial disease? We give them warfarin. We can add dispirin, but it's all aspirin. As soon as you add an aspirin to these patients, we should remember that they have an increased risk of bleeding. So the best is to give them warfarin at an INR of 2 to 3 plus aspirin. You can't give them warfarin plus aspirin and keep the INR 3.5 because that increases the risk dramatically. So if you have a patient on warfarin with antiphospholipid antibodies, you need to know whether they're on aspirin as well, because then you would decide on your INR value. You can even add for example, if they have recurrent arterial thrombosis, you may add one of the other antiplatelet drugs. And here you can see the guidelines. I'm not going to show you, we haven't got time. What do we do? This is a practical point. What do we do if a patient with antiphospholipid antibodies develop thrombosis despite, or with antiphospholipid syndrome, develop a recurrent venous thrombosis on anticoagulation? If the patient is on a DOAC, you switch them to lamictal and then switch them to warfarin. But if they're on warfarin, you check if the INR has been well controlled. If the INR has been well controlled, and you know the patient is reliable, and you know that they're not taking the warfarin haphazardly, then you consider doing a factor 2 level at the time where they have an INR of 3. And you correlate the INR with a factor 2 level. And you want that level to be 15 to 25%. If a patient has an INR of 3 and the factor 2 is 40%, you need to increase that. And until you get to a factor 2 level of, say, 20%. If that correlates with an INR of 4, this patient will run on an INR of 4, because they have antiprothrombin antibodies as well, and these antibodies will influence your INR level before they even take warfarin. You may do an INR on a patient without warfarin with antiphospholipid syndrome, and it will be prolonged already. So adding warfarin, you're not sure. That's a way to check. If they have recurrent thrombosis, what do? You increase it to 3.5, or you add an antiplatelet drug and keep it around 2.5, as I said, or you add hydroxychloroquine, or you change the modifier risk, stop smoking, treat the hypertension, diabetes. If they then have that, despite that, then you will consider immunosuppression, lamprey-white heparins, but this has got a problem in the sense that you may have long-term problems. What about bleeding in antiphospholipid syndrome? Also often underestimated. 40% of patients will experience bleeding. It's not only because of the anticoagulant, it's because of the disorder. And a small percentage will be major. 77% will be non-major. Most of them will be spontaneous, which is always worrying. And many of these spontaneous events will have a low platelet count as well. So which risk factors are there for a patient to start bleeding? The high-intensity warfarin, that's what I said, you would treat them still with a 2 to 3 if they're doing well. Combined warfarin with antiplatelets, or if the INR goes up and down. A patient that's really difficult to control, then it's 1.8, then it's 4.5. Those are the patients that bleed. As I said, thrombocytopenia. And here you can see where the bleeding are. You can see soft tissue, central nervous system, and almost 8% will have permanent damage. So it's a problem. Bleeding is also a problem in antiphospholipid syndrome. The question of should we continue permanently, just remember antiphospholipid syndrome, we should consider it in some of these disorders depending on the history and what happens to them. I'm going to skip that because we haven't got time. Just a quick thing, 2 minutes on catastrophic antiphospholipid syndrome. This is extreme accelerated microangiopathic storm. It's like what happened with COVID. This is a microangiopathic storm that happens in antiphospholipid syndrome, and it's 1% of patients. If you don't treat them, 75% of them will die. It reduces to 30%, which is also very high if you treat them properly, and there's steps to be taken. And what really happens is the diffuse microvascular occlusion in different organs. And it's really what we spent time on this morning, talking about immunothrombosis. And 66% of these patients start with a thrombocytopenia. We had a patient that had a platelet count of 8, and despite everything died with catastrophic antiphospholipid syndrome. So how do we make the diagnosis? You require all 4, but you don't often have all 4. The first is you have to have impairment of 3 or more organs. In other words, the patient have renal dysfunction, heart, and a thrombosis or a stroke. It must all happen within a week. You need histological evidence of small vessel disease, but you often don't have that. And you need to be sure that the antiphospholipid, this diagnosis is definite in this patient. And you can treat a patient if you think it's got a probable catastrophic antiphospholipid syndrome, because it's such a devastating disease, you can rather scale down afterwards. And here you can see which organs: 50% brain, heart 50%, skin less than 50%, kidneys 75%, lungs 60%. This is the failure in these patients. And they also have the thrombocytopenia. How do we treat them? I'm not going to spend time on that. We need to identify it. We identify the triggers. If a patient is poorly controlled with INR, and you start pushing that up without proper care, you can precipitate catastrophic antiphospholipid syndrome. Then you need to validate the criteria. As I told you, you've got 3 organs. It's within a week. Small vessels occlusion is logical, but you don't need to do it. And you don't need to wait, because most of the time, you know this is antiphospholipid syndrome patient anyway. And then you start triple therapy. You give them unfractionated heparin, you give them methylprednisone intravenous, and you do plasma exchange. And if you can't do plasma exchange, you give them intravenous immunoglobulin. And then you can also use eculizumab or tuximab, in other words, in these patients. So what have I said this morning? I said we should be careful to underestimate the risk of arterial disease in our patients with rheumatic disorders. You can see the blind spot in rheumatoid arthritis, and we know what is the pathogenesis. About venous thromboembolism, remember that systemic inflammation acts as a catalyst. It's driving the mismatch. I showed you that mismatch scale. In other words, you've got endothelial damage, you've got hypercoagulability, and often these patients are admitted. The high-risk profiles, the highest risk is the triple positive antiphospholipid. Your double positive Sjögren's are also high risk. The first stage of myositis. Then you've got danger windows, for example, admission of a patient in the first 90 days with autoimmune hemolytic disease and with the flares with your IBDs and vasculitises. How do we treat them? Do we give them indefinite secondary prophylaxis? I think so, if once they've had a thrombosis. The antiphospholipid syndromes, absolutely we should. That's my story.
Now, discussion, I think there's one thing that you highlight so beautifully, that we never know enough if you don't have ongoing education. And I think that's what they highlight, because we thought always we knew warfarin very well. We always have knee-jerk reaction. When the warfarin goes to INR goes to free, you omitting your warfarin, you start de-adjusting downward, and then imagine how much mortality could have been prevented. So I think we appreciate this so much, and this is really quite a very good lecture, and especially highlight the autoimmune disease that is a key thing in South Africa. Actually, our numbers are higher than what we actually know, because now, I think for the last couple of years, now we have a lot of pulmonologists, we have a lot of rheumatologists, a lot of good work is being done actually. And now we see most of these cases, unfortunately, that now we need actually to go on with the knowledge. So my question is that with the warfarin, that's quite very, that we need to go to INR of 4. What if you could only reach that levels of 15-20% INR of 7 or 8? What are the risks of bleeding? What are the studies saying? How safe am I?
You see, there's not really a study on checking warfarin with your factor levels. But the reason why we do it is that in the mix of antibodies that these patients have, they may have anti-prothrom antibodies. Those are antibodies against factor 2. So if you do their bloods without any anticoagulant on board, they will have a prolonged PT already. Remember, how we make the diagnosis of antiphospholipid syndrome is we do a lupus anticoagulant. That's a PTT. So we have a reagent that is sensitive to these antibodies, and that is prolonged. But then there are various reasons why a PTT can be prolonged. A patient can be on heparin. A patient can have a factor deficiency. And then we do further tests to make sure that this is really an antibody that causes this. We incubate and we check for an inhibitor. And then what we do, we use some snake venom, Russell Viper snake venom, that activates only some part of this process. And we can then confirm, depending on our results, and then we take out the effect of the platelets to make sure that this is really an antiphospholipid antibody. So the interesting thing is these patients, if you do a PI and a PTT on an antiphospholipid patient, that may be prolonged and you will think that they will bleed. It's not true. They will clot. It's only in the lab that it gives that effect. So the PT and the PTT will be prolonged. So it becomes, if you take a patient with antiphospholipid syndrome to theater and you use a activated clotting time, you're going to run into huge issues. For example, a patient with antiphospholipid syndrome going to theater and need a bypass surgery. What they do, they will use an ACT, the activated clotting time, to decide how much prothrombin to give, to reverse because they give very high doses of heparin. And you can with prothrombin, sulfate, reversing heparin, you can also make a patient hypercoagulable. You can have a terrible effect. And that's the issue here, is that if an antiphospholipid, and cardiologists and thoracic surgeons don't know this, but they should really do anti-factor 10 or factor 10 activity measures against ACT to know what ACT, because if they start, the ACT is prolonged already. It's the same here. So with warfarin, the PI is prolonged anyway. So now you're adding something on an already high level, but you're adding a little bit to get to what you think it should be. And that's where the problem comes in. It is the most difficult patients to control. They're the ones that worries me always for several reasons. One, they often have specific, they can have some crazy ideas in their minds. It's well known in SLEs and in antiphospholipid that they have this personality. And it's difficult. They decide on, we have one patient, she decides how she's going to take her warfarin. Then it's 5.2, then it's 1.2. And you can talk to them, you can explain to them, they don't listen, they do what they want to. That's the first thing. The second thing is that if you don't know that they may form a clot with an INR of 3, and once, because you can't test everybody's factor level against the warfarin. You can't do that. I mean, medical aids will kill you. But if a patient has a failure on warfarin and you know that the INR has been correct, then what we do is we do a factor 2. And the reason why we do a factor 2, we can do a factor 10 as well. The reason why we do a factor 2, it's got a long half-life, so it's stable. You know that factor 2 isn't, if you do a factor 7, you know, it's got a half-life of a few hours. It's not a reliable test. But if you do that factor 2 level, and you know, you have good effect of warfarin with a factor 2 of 15 to 25%, about 20%. That means the warfarin is effective. And if that is not 20%, around 20%, you know that INR is really a mix of the effect of the antiphospholipid antibody and not only the effect of the warfarin. So then you up your warfarin dose to have a, and you take that INR. For example, the patient's INR at 4.5 gives a factor 2 level of 20%. In the patient that had repeated thrombosis, that's what we do. We say this patient runs on a 4.5, but we're not scared. The thing that scares me the most is if you take a patient on warfarin and you stop their warfarin for 2 days. They normally take high doses, that's the first thing. And if somebody is on a 10 milligram or a 7.5 milligrams of warfarin daily, and you stop it for 2 days, they will drop their INR, even if it's high. If the INR is 5 or 6 or 7, the risk of bleeding is there for sure, but we should stop it for 1 day, repeat, or give half the dose a second day, just lower it slowly. Warfarin is a long end game. It's not a quick game. There's a recent article on 2 cases where people reversed warfarin, where both patients died immediately. Reversing warfarin without covering, depending on the underlying reason. If you have an intracranial bleed, you need to stop it. You need to reverse it. I mean, that's life-threatening. But acting on an INR in a patient, acting inappropriately on an INR in a patient with antiphospholipid syndrome is dangerous. You should lower it. You can give them a little bit of plasma if you're worried, but you should be very careful giving these patients reversal drugs like hemosolix factor, PCCs, because you push them into a hypercoagulable state immediately.
Anybody online or another questions? Been exciting.
We all want to go to work. Real work.
Yeah, so look, it's been a very good presentation, and thank you so much, Prof, for joining us all the time. It's been amazing, and I think we're actually on time. So thank you so much. I think for everybody, the presentation will be in podcast. You can log into our website at sanocare.com, Bread of Hope. That's where the podcast is, and will be available for live. And so it's really amazing to be listening to you and your knowledge. You know, always when I listen to you, I feel like I don't know enough. I need to kind of go back and study.
That's all what I know about. I know nothing about what you do. Have a good
but
day.
your passion for population has been amazing for the number of years since I get to know you. It's really amazing. I think keep doing a good job. I think you're actually inspiration for all of us. And we hope one day we'll reach about 1% of your knowledge. That would be quite a major achievement for us.
No. Okay. Have a good day.
Thank you.
Bye.